I think you have to stop sharing.
Yes, sir, I'm here, sir.
Yeah. Pragathi, you can go ahead with your presentation. I think your topic is clinical assessment of pulmonary valvular stenosis and pulmonary registration.
Just a second, sir. Let me share this.
Sure, no issue. Meanwhile, Dr. Shailendra Singh and Dr. Vijay Kumar, you can add some comment. Are you ready, Pragathi?
Yes, sir.
Okay. Carry on, Dr. Pragathi.
Yes, sir. So, can you see my screen?
Yeah.
Great, wonderful morning to all my teachers, my friends and colleagues. And first and foremost, I would like to thank my guide and mentor, Dr. Sridhar Kasturi sir, for having given this opportunity of addressing the upcoming cardiologists. And my dearest teacher, Dr. Shailendra sir and Vijay Kumar sir, to guide me throughout my residency. And I think this is a great platform to share the knowledge regarding the valvular heart diseases, which is the most exciting topic of clinical cardiology. And the pulmonary valve per se, it is often an understudied valve when it comes to rheumatic heart disease perspective, but it is often the most frequently considered valve when it comes to congenital heart disease. So I would like to discuss the valve in terms of congenital heart disease only. And so pulmonary stenosis is, by definition, there can be obstruction at any level of right ventricular outflow tract, be it at the level of valve or supravalve or subvalve. So it is an acyanotic congenital heart disease unless there is a right heart failure and there is a shunt reversal across the foramen ovale. And so it accounts to 10% of all the congenital heart diseases, and 50% of them come along with the complex congenital cyanotic heart disease. And it was first described in late 18th centuries by John Morgagni, and there is no gender predilection with this disease. And the instance, irrespective of the availability or utility of echocardiography, right from 6th decade of 20th century, it is the United States that has shown the highest prevalence of the disease without complex congenital heart diseases. And to classify, first and foremost is the valvular or valvular pulmonary stenosis, where there is obstruction at the level of pulmonary valve, and can be subdivided into domain, dysplastic, and bicuspid valve with fused commissures, or unicommissural or ecommissural, depending on the anatomy of the valve. And supravalvular pulmonary stenosis, aka pulmonary artery stenosis or coarctation of pulmonary artery, as classified by Gaze et al. The type 1, there is stenosis at the level of main pulmonary artery. Type 2, there is stenosis at the level of bifurcation of main pulmonary artery into right and left pulmonary arteries. And type 3, there are multiple stenosis in the peripheral pulmonary arteries. And type 4, the obstruction is expected at the level of main pulmonary artery and also the peripheral segmental arteries. And coming to subvalvular, it is infundibular, that is, there is obstruction at the level of conus, and DCRV, where there is an intracavitatory, that is right ventricular muscle bundle, which divides the right ventricle into a proximal high pressure chamber and a distal low pressure chamber. And, to speak about the etiology, etiology can be the cause for all types of obstruction in the right ventricular outflow tract. So acquired is true with valvular pulmonary stenosis and infundibular stenosis. So acquired causes rheumatic heart disease, where it affects most commonly the other valves. It is very, very, very rare when it comes to pulmonary valve. And infective endocarditis will cause pulmonary stenosis to begin with, but eventually it will cause medical valvotomy, and the patient will land in pulmonary regurgitation. And right heart carcinoid, RV thrombus, RV tumor, and echinococcal cyst will be the other acquired causes of valvular pulmonary stenosis. And coming to infundibular stenosis, most common congenital form will be associated with the most common cyanotic heart disease, that is DOF. And isolated infundibular stenosis is quite rare. And the acquired causes will be gussels. Gussel is otherwise known as gussalization, where the patient or the child will have moderate sized ventricular septal defect, and when the kid is around 5 to 10 years old, due to persistent left to right shunting of the blood across the ventricular septal defect, there will be hypertrophy in the right ventricular free wall. So that will cause obstruction to the right ventricular outflow tract. And there can be, infundibular stenosis can be associated with the valvular pulmonary stenosis, and RV HCM is also a possibility. And coming to syndromic association, Williams syndrome, where the typical phases of large, broad forehead and upturned nose, square-shaped chin, and large portulous lips with ear abnormalities and low-set ears. And here, supravalvular pulmonary artery stenosis also associated with supravalvular aortic stenosis, which might be the cause of asymmetric pulse in both the limbs. And coming to Alagille syndrome, here facial features will be small pointed chin and large baggy forehead. And Cornelia-Dillon syndrome, it is typical with microcephaly and crowded teeth and long eyelashes and eyebrows. And Noonan's, it is the male counterpart of Turner syndrome. Here, the affected patient will be short stature, stumpy, and with webbed neck and broad shield-shaped chest. And next will be rubella, congenital rubella syndrome, where the child will be intrauterine growth retarded, and there can be maculopapular rash associated with mental retardation as well. And CASH22 or discharge, it is association of RVOT obstruction with TOF. Here it is a conotruncal anomaly and velofacial cardial syndrome, and it is most often associated with other neural tube migration defects. Therefore, the child in this picture shows a cleft lip and cleft palate, which is because of abnormal neural crest cell migration. And chubby round face, where we expect opening pulmonary valve. Coming to hemodynamics of pulmonary stenosis, obstruction to right ventricular outflow tract increases the intraventricular pressure, intraventricular systolic pressure. Due to persistent increase in right ventricular pressures, there will be right ventricular hypertrophy and the muscle mass eventually increases. And gradually, there will be increase in right ventricular end diastolic pressure as well. And this is back transmitted to right atrial pressure, which reflects as a prominent A wave in jugular venous pressure. And eventually, there can be RV ischemia because of demand supply mismatch, and there can be RV failure. And this causes tricuspid regurgitation, which is reflected as a prominent V wave in jugular venous pressure. So tricuspid regurgitation further aggravates the already worse condition of RV dilation. And at this point, there can also be elevation in LV end diastolic pressure that can be due to variation in LV geometry, or due to chronically underfilled LV, there can be restrictive LV physiology as well. And eventually, once RV failures ensures, there can be a stretching of foramen ovale, and there can be shunting of blood from right atrium to left atrium. And eventually, the patient lands in sinuses and shows low saturations. And coming to critical PS, often intrauterine, there is absolute RVOT obstruction. Therefore, barely there is any forward flow across the RVOT. Therefore, the right ventricular pressures and end diastolic pressures are grossly elevated throughout. Also, the RV is hyperplastic, and the blood is shunted predominantly through the foramen ovale. And this is a duct-dependent condition, and for the patient to survive, probably the baby needs an intrauterine or fetal intervention. And severe pulmonary artery stenosis, the pressure in the arteries distal to the obstruction is low. Therefore, the lung perfusion is also low. Due to chronically decreased lung perfusion, there can be loss of lung parenchyma as well. Coming to clinical features, to brief with the dysplastic pulmonary valve, it is anatomically characterized by 3 mobile cusps without any commissural fusion. Here the valve cusps are thick and redundant and barely mobile. And this is the cause for the abnormal signs that are elicited during the dysplastic pulmonary valve, and it is a common association with the Noonan syndrome, and a strong family history is always there. And as said, there is absent ejection sound and absent P2 component of second heart sound. This is because of the immobility of the valve cusps, and the pulmonary trunk is often non-dilated. And coming to critical pulmonary stenosis, aka pulmonary atresia, here the pulmonary valve is described as a pinhole, and the neonates present with cyanosis, heart failure, hypotension, feeding difficulty, and tachypnea. So on auscultation, there might be barely any audible murmur since there is barely any forward flow across the RVOT. So ECG findings usually reveal left ventricular hypertrophy picture as the RV is hypoplastic. And coming to severe pulmonary stenosis, here the child will be symptomatic, the patient will be symptomatic right from his childhood, and cyanosis can be peripheral because of increased peripheral extraction of oxygen in consideration with the decreased cardiac output, but it can also be central because of the shunting of the blood across the foramen ovale from right to left. And the pulse volume is usually low with right heart failure, and there can be a giant A wave in JVP or a V wave with tricuspid regurgitation. There can be a grade 3 right ventricular heave, and second heart sound can be widely split with softer P2. So RVS4 is expected in any kind of severe pulmonary stenosis, irrespective of the level of obstruction. And there can be RVS3 if there is signs of right heart failure. There can be presystolic and systolic hepatic pulsation in par with the A wave and V wave in jugular venous pressures. Coming to mild and moderate, the patient is barely symptomatic, and still JVP may show prominent A wave. S2 is widely split with maybe normal P2 loudness, and rarely there can be RVS4. And an inconstant pulmonary valvular ejection click is expected in all kinds of pulmonary stenosis. Pulmonary stenosis. And this is the most important slide of the entire topic, where it is where all the differences between obstruction at every level is clearly enumerated. So it is better to completely understand this slide and memorize it so that we will be able to appropriately localize the level of obstruction. So coming to the association, Doming valve is associated with Cornelia de Lange or Chebby-Round-Face syndrome, and Noonan's is seen with dysplastic valves. And TOF has most common association with the bicuspid valve and infundibular obstruction. DCRV, 90% of the cases of DCRV are associated with the ventricular septal defect, and pulmonary artery stenosis is more predominant in children with congenital rubella syndrome, Williams, and Alagil's. And there is a normal birth weight and growth pattern in Doming valves and DCRV as well. Whereas usually the child has low birth weight in dysplastic and bicuspid valves, and also infundibular obstruction. Mental retardation is more common with children born with congenital rubella syndrome and Williams and dysplastic valve. The pulse is okay, sorry, sir. And the pulse is low volume once RV failure ensures, and it can be asymmetric if it is associated with the supravalvular aortic stenosis as with the Williams syndrome. And JVP, as already described, there can be prominent A waves with the B waves once right heart fails and tricuspid regurgitation ensures. So this is common with all the types of right ventricular outflow tract obstructions. And thrill and an ejection systolic murmur always go hand in hand in consideration with its site, and it is best heard and best felt at the level of obstruction. So in valvular pulmonary stenosis, it is best heard in the left second intercostal space, and it always radiates to the left. because the left pulmonary artery is in line with the main pulmonary artery. And in infundibular obstruction, the thrill is best felt in left, third, and fourth intercostal spaces. And DCRV, it is felt lower down, that is in the fourth and fifth intercostal spaces. And peripheral artery, pulmonary artery stenosis, the thrill and murmur, they are best felt and heard in the non-precordial sites at the level of obstruction. And coming to ejection click, as described, it is an inconstant pulmonary valvular ejection click. It is seen only with doming and bicuspid pulmonary valves, and it is absent with the dysplastic valve as the valve is barely mobile. Valve leaflets are barely mobile, and it is also absent in infundibular obstruction and DCRE and peripheral artery stenosis. And coming to split of second heart sound, it is wide and variable in almost of all the types, except for dysplastic valve where P2 itself is absent because the valve is barely mobile. And loudness of P2, it is inversely proportional. It is inversely proportionate to the severity of obstruction. So the loudness decreases with increasing severity in most of the types, except for in DCRV and pulmonary artery stenosis. And so, as already discussed, systolic murmur goes in par with the thrill. And diastolic murmur, it is heard in very few types, like likewise in doming valve. This is due to possible coexisting pulmonary regurgitation, or there can be a presystolic flow across the pulmonary trunk. And continuous murmur can be expected in pulmonary artery stenosis, and a proposed theory is bronchial artery collaterals. And S4 is seen in all the severe types of RVOT obstruction. So the most important auscultatory signs would be ejection systolic murmur and loudness of P2 and split of second heart sound and S4. So in mild, we don't expect an RVS4, that is, there is no presystolic diastolic sound. There is a appreciable gap between the first heart sound and the ejection click. And the systolic murmur is classically described as a kite-shaped murmur with the crescendo-decrescendo pattern, and it will end fair enough before the A2. And the split between A2 and P2 is wide, but P2 is yet clearly audible. And so with increasing severity, to brief down, the murmur and ejection click component moves close to the first heart sound with increasing severity. So sometimes the first heart sound and the ejection click combines, and the first heart sound is heard as a loud first heart sound. And but the respiratory variations is still maintained by the ejection click. That is, ejection click of pulmonary valve is it will vary with respiration. That is what I meant by inconstant ejection click, and it is best heard during expiration and less heard during inspiration. That's how it will violate the Carvello's rule. And to brief about double chamber right ventricle, there is intracavitary muscle bundle which separates it to the proximal high pressure chamber and distal low pressure chamber. It is often an acquired cardiac defect, and there is a strong genetic predisposition for it, often associated with the perimembranous ventricular septal defect. Almost in over 90% of patients, it is an association. And it is also described if there is no associated ventricular septal defect, it is always thought that it is because of the closure of already existing defect. So majority of the cases are present in early life, but infrequently they may also extend into adulthood. And congestive heart failure or infective endocarditis, pulmonary regurgitation due to infective endocarditis induced medical valvotomy, and post-intervention or post-op situations. Atrial and ventricular arrhythmias because of dilation of RA and RV are the supposed complications of this valve lesion. And atrial septal defect and subpulmonic ventricular septal defect, acyanotic TOF, are often diagnostic dilemma. And though ECG and chest X-ray is not part of the discussion, I just briefed them because without this, the talk would be incomplete. And this is a brief slide which shows the ECG changes in RVAT obstruction. So with increasing severity, their right ventricular hypertrophy is expected. There is also right axis deviation, and right axis deviation as high as greater than 110 degrees is expected with severe pulmonary stenosis. And with increasing severity, the R by S ratio in V1 increases. The R wave goes beyond 20 millimeter of height with severe. And a right ventricular conduction all the types of pulmonary stenosis, irrespective of the severity. And patients age ranging between 2 to 20 years, we can estimate the right ventricular systolic pressure by means of pure R wave height in lead V1 by the formula height of R wave in millimeter into 5. Whereas there are also significant exceptions to these ECG changes. Likewise, in patients with Noonan's, left axis deviation is expected with splintered QRS. Even in rubella syndrome, it is the left axis that is expected. And those with double chamber right ventricle, the RV hypertrophy is not really significant. The only lead which points out or which gives a clue towards it is the right-sided V3 lead, which will show prominent QRS complex with upright T wave. And coming to chest X-ray in just a moment, sir. Just a moment, sir.
आज 500
Ignesh, try to mute all others except speaker. Pragathi, you have to unmute.
Sorry for the inconvenience, sir. Somebody's mic is on.
Ignesh, see that all other, just mute all other except Pragathi.
Okay. So coming to chest X-ray, post-stenotic dilation or MPA dilation is expected with the valvular pulmonary stenosis, in specifically the doming and bicuspid valve, whereas in pulmonary artery stenosis or infundibulous stenosis or dysplastic pulmonary valve, we don't expect a post-stenotic dilation. However, chamber enlargement is common with all the subtypes. And specific infundibulous stenosis, which is most common association with the TOF, right aortic arch is expected in around 25% of cases. And so mobile dome-shaped pulmonary valvular stenosis, sometimes the MPA is so grossly dilated and aneurysmal, which is seen in the angiocardiogram. And, coming to natural history, this is one of the examiner's most favorite question to the residents. And natural history, it always depends on the severity of pulmonary stenosis, type of stenosis, and associated lesions and the syndromes, and any childhood interventions or intrauterine interventions. So mild pulmonary stenosis is often benign, and a study done by Levine, which followed up cases for 4 to 8 years, and the study is done in 214 patients around. So there were no deaths in the follow-up, and if the gradients is less than 25 millimeter of mercury, it is unlikely that the disease would progress. And in moderate pulmonary stenosis, it progresses with age, and it is asymptomatic till the adulthood is achieved. And severe pulmonary stenosis, the child is symptomatic since infancy, and survival into adulthood is very difficult without intervention. And pinpoint pulmonary stenosis, often considered as functional pulmonary atresia, and it is a critical form of pulmonary stenosis, and it is a drug-dependent condition, and it has got grave prognosis. And a fetal cardiac intervention is must for the fetus to survive. And DCRV is acquired later in life, and the severity gradually progresses with age. And pulmonary artery stenosis is usually non-progressive, and it may regress in age, in severity with age. And so coming to mortality, as said by Campbell, it is around 2%, 3.56, 7% per year in first, third, and fourth decade respectively, and the most common cause of mortality being heart failure and congestion. And there can be cases with sudden cardiac death. The most likely etiology would be RV infarction due to RV hypertrophy or an abnormal RCA coursing across the right ventricular outflow tract, or there can be a rupture of a massive intrapulmonary aneurysm. And infective endocarditis is expected with doming pulmonary valves, and medical valvotomy can cause the resolution of PS, but the patient lands in pulmonary regurgitation. And to brief about congenital PR, not much we really read about it. And the etiology would be congenital with TOF. Around 5% of cases, absent pulmonary valve is associated, where there is simultaneous pulmonary stenosis and pulmonary regurgitation. There can be a pulmonary congenital pulmonary valve abnormality, or there can be idiopathic dilation of pulmonary artery. And the acquired causes, most common would be post-intervention, that is post-balloon valvotomy, or it can be a post-op case as with TOF surgeries or any conduit repairs or conduit surgeries, right heart carcinoid, rubella, and infective endocarditis. Graham still, which is the most commonly seen clinical condition, that is high pressure PR. That means the pulmonary artery is hypertensive and the valve regurgitates. Coming to pathophysiology, long time pulmonary regurgitation, that too severe pulmonary regurgitation, leads to right ventricular volume overload, which leads to subsequent right ventricular enlargement and right ventricular dysfunction and causing functional tricuspid regurgitation. This leads to atrial and ventricular arrhythmias, which contributes to the mortality and morbidity. Clinical features are, most of the times the patient is asymptomatic unless and until the disease is very severe, and heart failure in neonates is very, very rare. And the signs would be pulse and JVP are expected to be normal until right heart failure ensures. Once right heart ensures, and second heart sound is wide split, secondary to increased RV ejection time and right bundle branch block. And P2 is expected to be soft or either absent depending on the valve morphology. And there can be a RVS3 with right heart failure. There can be a flow murmur that is described as an ejection systolic murmur. There can be a right-sided Austin Flint murmur as with aortic regurgitation, similar to aortic regurgitation. There can be a mid-diastolic murmur of congenital PR or an early diastolic murmur of hypertensive PR. And we can see the differences between mid-diastolic murmur of congenital PR and early diastolic murmur of hypertensive PR. Mid-diastolic murmur of congenital PR is classically low pressure PR that is low pitched soft sound. There can be a delay in the onset of murmur, like there can be a audible gap between P2 and the murmur initiation, and the murmur is of short duration and it ends well before the first heart sound. In contrast, the early diastolic murmur of hypertensive PR, it is a high pressure PR, hence the high pitched loud sound. It originates quite after the P2, and often we might not be appreciate any gap between P2 and the murmur initiation, and the murmur is of long duration and ends quite with first heart sound. And the natural history of pulmonary regurgitation. If the patients are followed for 20 years, 6% may develop symptoms. If followed for 40 years, 29% may develop symptoms, according to Shimazaki study. And ECG usually shows volume overloaded pattern of right ventricle. And however, right bundle branch block is uncommon. And this is the slide that can show the difference between congenital pulmonary valve regurgitation, idiopathic dilation of pulmonary artery, and pulmonary artery hypertension, which means that it is a high pressure PR. So I would not talk on each and every point. I would just enumerate the important points. So as already explained, the murmur would be high pitched with pulmonary artery hypertension, whereas it is low pitched and soft with congenital pulmonary valve regurgitation. And ejection click is expected with pulmonary artery hypertension and idiopathic dilation of pulmonary valve, which is vascular. And RV pulsations are expected with congenital pulmonary valve regurgitation and pulmonary artery hypertension. But idiopathic dilation of pulmonary valve, the RV is exceptionally normal. So that's it, sir. These are the points I wanted to enumerate, but since it is a vast topic, there is a lot of scope and questions expected to the residents. Here I have not covered absent pulmonary valve, as it is often associated with TOF, which is a cyanotic heart disease, and pulmonary stenosis with atrial septal defect, TOF per se, and pulmonary stenosis with intact ventricular septum versus TOF is always a favorite discussion. And pulmonary stenosis with intact ventricular septum versus pulmonary stenosis with ventricular septal defect, and isolated pulmonary stenosis versus pulmonary stenosis with atrial septal defect, and pink-TOF versus pulmonary stenosis, pink-TOF versus double-chambered right ventricle, and oximetry and cardiac catheterization. These are the topics to be covered for the topic to be complete. And this is it, sir. I have included few questions. So here is the child with peculiar faces, apparently asymptomatic, and on routine evaluation was found to have an ejection systolic murmur in the left second intercostal space and an asymmetric pulse. So the syndrome associated is Williams, because the supravalvular pulmonary stenosis is also associated with supravalvular aortic stenosis, hence the asymmetry in pulse. Here, a 19-year-old woman, apparently asymptomatic till she was 19, was found to have an ejection click and a systolic murmur on routine evaluation. Now she has become symptomatic. So, given the clinical suspicion of worsening pulmonary stenosis, which of the following physical examination would not be expected? So here, the systolic ejection click is more prominent in inspiration is a wrong statement, as the ejection click is well heard during expiration, not during inspiration, where it violates the Carvallo laws. And this ECG is consistent with which type of pulmonary stenosis? Here the LV forces are predominant and hardly any RV forces are seen. So the most likely cause is critical or pinpoint pulmonary stenosis. So none of the above would be the answer. And a 25-year-old woman complained with 6 months history of shortness of breath and a systolic murmur, a delayed but well-preserved P2. So initial ECG and chest X-ray showed right heart enlargement, and echocardiography showed normal pulmonary valve cusps and a prominent presystolic wave and normal MPA diameter. So which of the following is the most likely diagnosis? It would be the infundibular pulmonary stenosis, as the MPA diameter and valve morphology is normal. And the feature that is not common between a severe pulmonary stenosis with the shunt reversal across PF4-AST and TOF would be inconstant pulmonary ejection click. So inconstant pulmonary ejection click is expected only with the pulmonary stenosis, with or without shunt reversal. TOF, it is the inconstant aortic ejection click that we expect. This is it, sir. Thank you.
Yeah, thank you, Pragathi.
Thank you, sir.
We will move on to the next topic. you have extensively covered. Dr. Shailendra Singh and Vijay Kumar, meanwhile, you can add some comments. Then I would request Dr. Bucks to present, I think, clinical assessment. Tushar, because I will request Bucks to present because she presented pulmonary valvular stenosis and PR. So relevant echo findings, that pulmonary echo assessment. After that, you can proceed with the multivalvular assessment.
Okay.
Bucks, nice to see you.
Thank you. Thank you. Nice to see you all, sir. It's pleasure always to be associated with you. Very good morning to you all.